Today for our FD seminar, I'll be talking about sex differences in chronic kidney disease and the outcomes associated with chronic kidney disease and how they differ by sex. So I am presenting using some data and analyses and things that came together through mostly two sources. So the Birch, which is a funded K-12 program here at Tulane, which it has junior faculty who want to do research in sex differences, and so I'm the director of the Women's Health Resource Laboratory for that program, and also the Chronic Renal Insufficiency Cohort Study, which I've worked on for many years. Some of the output that I'll be showing is from that and some other sources as well. So today I will be going through, hold on. Just a few things. So for those of you who haven't done sex differences research or aren't familiar with it, I just want to give a very brief background of why we do it and some of the considerations from funding agencies currently. I'll talk about the kidneys, and so we'll go a little deeper dive into kidney anatomy and physiology, and I'll talk a little bit about chronic kidney disease, how we define it, how we define kidney function, and there's a lot of issues with measuring and kidney function that really relate to sex differences, but many outcomes as well. Reliability of diagnostic tests based by sex, and we also can have different responses to treatment. And there's a whole host of reasons why we see this. Some of them are based on sex hormones, others are differences at the biological level for other reasons. And because of this known difference across sex, it's important for us to study when we do clinical research to include both men and women is relevant, but also to look to see if response to treatment or differences in risk factor presentation show up that differ across sex and or gender. And so funding agencies have more and more recognized the importance of looking at sex as a biological variable or gender to understand how things differ across different sexes and genders. And so as a result, it's become more and more of a mandate. So in 2010, the Canadian Institute of Health Research mandated that at least researchers who are applying for funding address whether or not they've included an investigation of sex or gender differences. And that really pushes you as an investigator to make sure you understand, is it important that I look at sex differences? Should I include gender differences? And to provide a justification. Soon after that, I think in about 2014, European Union funding agency made that a mandate as well. And so you have to explain why you did or did not include a specific look at sex differences. And then even though it was back in 1993 that there was an NIH Revitalization Act that said that women need to be included in all clinical research in the United States, it wasn't until 2015 that NIH mandated that anyone applying for funding has to have some justification and some statement about sex as a biological variable, how they handled it in their research. So they have to address it, and that really pushes investigators to think about it. Did I include sex differences as one part of the component of my study? Should I or shouldn't I, and to provide a justification? So this is why we do this research, generally speaking. And now I'm going to shift our focus and really think about my main area of study is chronic kidney disease, which is a slow loss of kidney function over time. We talk about the GFR, which is the glomerular filtration rate. I mentioned it in the outline. It's the rate at which the fluid component of blood is filtered by your kidney. This is accepted as our best index of kidney function. Unfortunately, those of us who do kidney function research, we're always trying to figure out the best way to estimate kidney function or to measure it. And there is no really direct way to measure kidney function. And so we're really always grappling with what's the best way to do it. And I'm actually going to show you some very, very recent papers, one of which that I'm involved in, where we actually just changed our estimating equations to measure or estimate kidney function. And then finally, the end stage of kidney disease, we call it end stage kidney disease. There's a couple different terms that are used over time, but that is the complete or almost complete loss of kidney function. It requires you to go on dialysis to filter your blood, or you need a kidney transplant. Okay, so I'm going to give you a lot of information about the kidneys. I'm not going to dive too deeply, but I want you to understand the physiology, the anatomy of the kidneys, so that we can really talk about why we might see some sex differences and how they might show up. So the kidneys are a pair of fist-sized organs toward the back of the abdomen. And I'll show you a picture on the next slide where they're located and what they look like. And their primary function is to filter the blood. So we need them to filter our blood. All of our blood in our body passes throughout the kidneys several times a day to remove waste, to remove extra fluid, to balance our extracellular fluid volume, regulate electrolyte concentrations, and maintain acid-base balance. In addition, our kidneys also help with hormone secretion. So it helps regulate erythropoietin, or EPO, which stimulates bone marrow to make new red blood cells. It regulates renin, which moderates our blood pressure. And it also moderates calcitriol, which is an active form of vitamin D that helps maintain calcium for our bones. So the kidneys are extremely important. They help us filter things, but they also regulate a lot of different things and systems within the body. So here's a couple of pictures. First, let's look on the top right. So the kidneys are here. You can see one is up, a little higher than the other. They're slightly different in size. I'll get into that over the next couple of slides. And they drain out through the ureter to our bladder where our urine leaves the body. On the left-hand side, this is just a depiction of a cross-section of one of the kidneys. And there's a cortex, that's the middle part here. And then a lot of what we think about happens in this part out here toward the outside. This, all in its entirety, this whole thing right here is called a nephron. And it includes this little, it's like a ball of capillaries called the glomerulus. And then that is where filtration happens. This is where things get filtered out of the blood. And then it passes through this yellow structure, which is we call the tubule. So there's the proximal tubule and the distal tubule. And different things come in and out and secrete and get excreted in the tubule. And that is how our body balances and maintains all of this, the homeostasis that I just talked about in the last slide. So I'm showing you all of this detail because I am going to talk a bit about the glomerulus and the glomerular filtration rate. So I want you to be able to picture that's what I'm talking about when I'm talking about GFR and filtration. And then there's also things that happen in the tubule where things go in and out. And so we have to think about that when we estimate kidney function. And that's the first step to understanding, does someone have normal kidney function or do they have abnormal kidney function? So we can define who has disease. So a little bit more about the nephron. So the nephron is that glomerulus with the tubule attached. Each kidney has about 1 million nephrons when you're born. And it includes the filter, the glomerulus, and the tubule. And the glomerulus lets the fluid and waste products pass through it. However, it prevents larger items like blood cells and large molecules and big proteins from passing through. So you retain those in the blood. Other things filter out the extra fluid and the smaller molecules. And the filtered fluid that passes through that tubule, which approximately 99% of the initial filtrate, is reabsorbed and returned to the blood. But that is how our body gets rid of waste products and excess fluid. Your number of nephrons, this is really important, it does not increase after birth. So you're born with about 1 million in each kidney, and if you lose those nephrons, they do not get replaced over time. So when they're damaged, they are not regenerated, and you need about 1/3 of your nephrons in a kidney for it to be a functioning organ, for it to really do what it needs to do. So let's keep that in mind as we talk in the next several slides about kidney function and also what does it mean to have abnormal kidney function. So getting back to sex differences. So do kidneys differ by sex? And this has been a long-standing question. There's been some small studies here and there. But it really wasn't until this nice paper by Kaluki and colleagues in DMC Nephrology last year, where they definitively did a very, very large autopsy study of healthy men and women. So a lot of the previous studies might have used imaging, which is imperfect, right? And you can't really get weights from imaging. They recovered some kidneys, but a lot of them didn't account for differing body sizes from person to person. And that's something that we should also consider, because your kidneys will be proportional in many cases to your body size. So this nice autopsy study included healthy men, healthy women, and compared both absolute and relative to body size, weights and lengths of the kidneys. So this really was more of a definitive study, and it's amazing that it didn't happen until 2020, but it's great that we have this information now. So these are some of the main figures from this paper. They all show the same thing essentially. So there are right kidneys that are shown in any of the gray box plots, and the left kidneys are depicted in the white box plots. And so this top left panel, we're looking at absolute renal weight, and we're looking at right kidneys versus left kidneys, first for men and then for women. And so generally speaking, we see that the left kidney weighs a little bit more, and that's statistically significantly higher than the right kidney. And so that's true for men, that's true for women. But then when we also compare right kidneys for men and women, we see that men have a higher weight of their right kidney, and they also have a higher weight of their left kidney. And that's true for absolute renal weight adjusted for body weight, and renal weight adjusted for your BSA, which is your body surface area, so all of the area of your body. So we see that there are differences in renal weight by sex. And this is also from that same publication. This is just another depiction of renal weight. This is absolute renal weight across the lifespan. So these are all healthy individuals. And we see there is a different pattern. So first thing that we notice here is there's a lot of splay, there's a lot of variability among different people. But on average, you can see that in men on the left-hand side, it tends to increase until about middle age. Maybe at about 55 years of age or so, you start to decline, and then it just declines pretty quickly in older age among men. But we do notice there are higher renal weights in men, but we don't see that same arching pattern in women. So we see that it's a little more flat over time until middle age. And then again, about 55 or 60, we see a decline, but it's more of a moderate decline in women. It doesn't drop off as quickly as it does with men over age 80. So there are differences in renal weights across the lifespan, across the sexes. So this is just kind of a summary of what that paper found. So adjusted for body size, men had higher absolute renal weight, absolute length, and relative renal weight. Women had higher relative renal length. So in other words, women's kidneys were a little more elongated. So the shape was a little bit different of a woman's kidney. And other studies have also noted some differences in anatomy. Some have found a larger cortex in women. So the anatomy of the kidney differs a little bit by sex. And also other studies have found lower nephron numbers. So that's important to remember, because we need those nephrons for our kidneys to do the function that they're there for. So why are we interested in measuring kidney metrics? Well, because hopefully I've conveyed to you how important the kidney is. We want to make sure that our kidneys are healthy and that we don't have any form of chronic kidney disease or acute kidney disease. But we also want to estimate the prevalence of those diseases. So it's really important as epidemiologists for us to be able to say, what is the burden of disease? And so all of this background and a few more slides that I hope you will tough it out with me and learn a little bit more about estimating kidney function. But we need all of that work to estimate how big of a burden is this disease and this condition in our population and other populations. We also use it so that we can understand if diminished kidney function is an exposure that means that you're at higher risk for certain outcomes. And indeed, people with chronic kidney disease have worse outcomes. They have a lot of cardiovascular disease, and they have more premature deaths, unfortunately. And they have end-stage kidney disease. And measuring kidney function also helps us, those of us who do kidney-related research or nephrologists, to actually define certain stages of kidney disease, so that's an outcome in and of itself. Or a lot of the time we're talking about how long does it take for someone to lose half of their kidney function. And so that's an outcome in and of itself. So we need these measures or estimates of kidney function. What do we aim to measure when we're thinking about kidney health? There are two components basically. One is kidney function, which we talked about with glomerulus. We want to know how well are we filtering. The other is if there's kidney damage, and that relates to that tubule that moves down further into the kidney, because we want to know, are we losing things or not reabsorbing things that we're supposed to or not supposed to? So kidney damage, we think about the tubule. Kidney function, we think about the glomerulus. There are a lot of ways to measure kidney function and damage. We use urine assays, so we look at how much protein or albumin is being excreted in your urine. It should be very, very low levels normally, and if you have that in your urine, that's a sign of early kidney disease, and it's also a prognosticator of worse outcomes. We typically rely a lot on blood assays. Serum creatinine is one that we use the most. Serum cystatin C is another one that has some issues in its measurement, but it has been recommended to be used more, and I'll get into that in a few slides. And blood urea nitrogen is also regulated, and we want to make sure we understand the levels of that marker in the blood as well. So there are filtration tests that we can perform. These are our best guess at trying to actually measure kidney function. I'll very briefly talk about some of those. Those are very error prone. There are a lot of issues with these. These are not perfect. And so most of the time we're left with estimating GFR, estimating kidney function. So a lot of thought, a lot of work over many, many decades has gone into developing and updating GFR estimating equations. That is the standard. That is what we rely on. And you can also do some renal imaging and kidney biopsy, but those are done less frequently. So just to reiterate, GFR, we calculate it by measuring any chemical that is it's supposed to be at a steady state in your blood. It's not something we want to fluctuate a lot because we want to be able to get a consistent measure of it. So something that stays at a steady state in the blood and that is freely filtered at that glomerulus, but it's neither reabsorbed nor secreted by the kidneys. So we don't want to have anything interfering with how the tubule is working. We really just want to zero in on that glomerulus, how well it's filtering. This is our glomerular filtration rate. The marker that we use the most, we call it an endogenous marker because it is in the body just by nature. It's a waste product from the blood from muscle. This is serum creatinine. So there are a couple different ways historically that we have looked at estimating kidney function. The first is, I'll mention it because of the history. Creatinine clearance is the volume of blood plasma cleared of creatinine per unit time. It was probably one of the first estimates to approximate GFR, but it is not an exact estimate of GFR. It's measured by the quantity of a substance in the urine that originated from a calculable volume of blood. And the GFR is typically recorded in units of volume per time. So when we talk about GFR, we're always talking about mils per minute, milliliters per minute. And for creatinine clearance, that's the units that we use. And we take into account urine concentration, urine flow over the plasma concentration of creatinine. So what makes an ideal marker to measure GFR? I've mentioned this before, I'm just going to put it here so it's all in a single list. So something that's distributed freely throughout the extracellular space, something that doesn't bind to those big plasma proteins because that hinders it from going through the glomerulus. It's freely filtered. That means it just flows right on through that glomerulus, all those capillaries. It's not excreted, it's not reabsorbed by the tubules. And it's resistant to degradation and elimination from the body elsewhere. So something that doesn't get eliminated through stool or something like that. We really want to just zero in on the kidney. We also want something that's easy to measure and safe and inexpensive. So that's our laundry list of things we like for something to measure GFR. These filtration tests, so when we use endogenous markers, we're not giving anything, introducing anything to the body. Here we use, again, creatinine as one of our measures. And how do we do this? We look at timed urine and blood collections. But these are very cumbersome. They're very hard to do. It's very prone to error. And so even when you do these tests, we think they're the best that we can do. Oftentimes, But we just get an estimate still. I just consider these estimates. These are not really a direct measure. In addition to filtration, a serum level of a marker can be affected by other things. So you always have to think about, if I'm using a specific marker, is it something that the tubule can secrete or reabsorb? Does the generation of this endogenous marker change by other characteristics? So men and women have different levels of muscle mass, and so creatinine levels are often different. So we have to take into account some non-GFR determinants of the marker that we decide to use, and we also need to make sure that it's really not extra-renally eliminated. When we use exogenous markers, this is what we call our gold standard. So this is when you measure either urinary or plasma clearance of an ideal marker, you inject it into the body. We use inulin, iothalamate, a lot of these are radioactive. And we measure the clearance of these markers, but it is complex, it's costly, and I can tell you people hate doing it. It takes hours to do these tests. You have to have an IV, you have to repeatedly give urine samples, and there's just a lot of issues with this. I could go into all of the issues with this kind of measurement for another seminar, but really, we do this as our best marker. This is our gold standard, but it is fraught with error as well. This is what we have, though. And the error, unfortunately, increases at higher levels of kidney function. So if your kidneys are working very well, we see a lot of error in that range in this type of test as well. So we can get false positives if we're thinking about detection of kidney disease, even if you have really high functioning kidneys. Okay, so thinking now that we have a really good idea of what is GFR, now let's get back to sex differences in GFR. So this is for men and women, men on the left-hand side, women on the right-hand side. And this is, again, over the age span. But instead of looking at renal weights like the last figure showed, now we're looking at inulin clearance. So this is one of our gold standard measures, the absolute best we can do in trying to measure kidney function. And this was done in a lot of people. And we can see that at younger ages, so in young adulthood in men, average kidney function is about 140 mils per minute, and this 1.73 meters squared here throws some people off. That is just the average body surface area of an adult, okay? So it's all indexed to one body surface area, so we can compare apples to apples. So in men, in young adulthood, the average GFR is about 140, but you can see that declines quickly and in middle, all the way up through middle age. And then we have a little bit of an inflection point and it kind of declines a little faster. And then we have another inflection point here at about age 60 where GFR declines pretty quickly among men. And these are healthy men. But there is a lot of splay. So there's a lot of difference from person to person what their typical GFR is. And then on the right-hand side, we see for women, there's maybe a little less splay. But here, the starting GFR at young adulthood is just above 120. And then it declines a little bit, but it's pretty stable over time until about 40 or 45. Then there's a little faster decline, and then again, a faster decline that starts at about 55. So the pattern of GFR over the age span really differs. And it's important to note, people who do kidney disease research and nephrologists kind of say 120 is the average GFR, healthy GFR for adults. But now you know, it really differs by men and women, and it differs by age. So you have to keep that in mind. There is something called age-related decline in kidney function. It's just a normal aging process. We don't typically call this decline in and of itself disease or a condition. This is just kind of age-related natural decline. Okay, so when we estimate GFR, we use information on one or more of these endogenous markers, usually. We almost never do those really cumbersome tests where we inject things. But we also have to include other variables to the extent that we can that address those processes and those other things other than what happens at the glomerulus. So we have to include anything that explains different generation of any of the endogenous markers, if there's any extra renal elimination, so anything getting out of the body other than through the kidney, and anything that tries to capture information on secretion and reabsorption. Okay, so the Cockcroft Vault was made in 1973. That was our first measure of creatinine clearance. The units are mils per minute because they're not adjusted for that average body surface area. And what we know is that Cockcroft Vault is a measure of creatinine clearance, not exactly GFR, and so it overestimates GFR because it doesn't take into account the tubular secretion that happens at creatinine. So that was used for many, many years. And then in 1999, the Modification of Diet and Renal Disease Study, this was one of the seminal studies in kidney disease research, developed an equation. It was later re-expressed. And here it's got that 1.73 meters squared part of the units because it's adjusted for average body surface area. And later, I can't remember the year off the top of my head, it was re-expressed because serum creatinine assays were standardized across the US and across the world. And so now we had a little different expression of the coefficients in this equation, but it includes terms for all those extra filtration things that accounted for differences in serum creatinine, and that included sex. And as serum creatinine generation differs by sex because it's related to the amount of muscle in the body. Okay, so we had the MDRD study equation, very popular from 1999 on. We had the Cockcroft Vault, which still held a lot of sway because people use that a lot for understanding medication dosing. They've both been used extensively up until that point, and they performed reasonably well in people who already have kidney disease, and that's because MDRD was done among people who had kidney disease, and so usually the equation performs the best in a similar population. So it doesn't do as well in healthy populations. It also doesn't do as well in older people and obese populations, unfortunately. MDRD does a little bit better than Cockcroft Vault in those, but it really doesn't do well in all of them. And a major limitation of performance is really in the range where I told you a GFR of 120 is considered healthy. People who have smaller declines, maybe in the range of 60 to 90 in their GFR, that is when you consider someone might have early stage kidney disease if they also have some protein and albumin in their urine. But this is early stage kidney disease or almost at the cusp of having kidney disease. MDRD underestimates GFR. So you might over-detect or overcall a diagnosis of CKD in these populations if you're using MDRD. So there's a lot of work still to be done. So because of that, there were collaborations of a lot of study groups that were funded. They were called the Chronic Kidney Disease Epidemiology Group, the CKD-EPI group, and they realized that we may not be able just to rely on creatinine because it does have some issues as a filtration marker, but they wanted to do better at predicting or estimating GFR at higher levels when someone is really at that important part where, like, do they have disease or do they not have disease? We want to make sure we were doing better. So they also looked at other filtration markers, endogenous markers, including cystatin C. It's not really widely available, although it's becoming more and more available. And I suspect with the very recent publications in the last month or two, it's going to be pushed as something that we do clinically, pretty typically for people who think that they might have some issues with their kidney function or have high risk, other risk factors. So now we have new equations. Very quickly, I'll show you how they do better in that really important range of GFR. But really, this has been developed across the whole range of GFR as opposed to just people who have disease. And multiple equations from this group, the CKD-EPI group, generated a serum creatinine only equation. It includes things like sex. It also includes race and age. And I'll talk just for a second about that on the next couple of slides, how there's been a call to eliminate the use of race because it's a social construct, and to eliminate it from these, to get rid of some racial inequities in saying when someone can get a kidney transplant, when they should get prepared for dialysis treatment and the like. And now we also have some cystatin C equations that have been harmonized to some international references. So because I wanted to highlight some sex differences work here, I'm also highlighting there have been many GFR estimated equations that have been made over time. These are just a couple that use beta trace protein, BTP, and beta 2 microglobulin, B2M, to try to come up with better estimating equations. Some people have worked on this for decades. How do we improve our estimation of kidney function? And we look for many other factors. These equations are less accurate than the existing CKD-EPI equations, so they have not gotten any ground, like no one's really started to use these. But these two markers are less influenced by age, sex, and race. And so it was something that we were excited about, but something that didn't get a lot of traction. So hot off the press, I just wanted to show two papers that just came out in October, so last month in the New England Journal. Several of us here, Catherine Jonha and I, are part of this CRIC-based paper. And over the past year, a joint task force of the National Kidney Foundation and the American Society of Nephrology worked on providing new estimating equations for GFR to eliminate race as a term that's included, because we want to make sure that there is not a systematic reduction in someone's ability to get a transplant because of a race correction. So a race correction, usually it will say that someone, if they are Black, their GFR is estimated to be higher for the same level of serum creatinine than a non-Black individual. So we want to eliminate that, and there was everyone in the community, in the nephrology community, agreed with this. We want to make sure that we're getting rid of that structural inequity. And so, and I said this month, but October, new equations were published by the CKD-EPI group. This is Leslie Inker and her colleagues, but also the CRIC study group. We are the largest chronic kidney disease cohort in the US. And so we also contributed some really important data to this. So these equations point toward a less biased and a more accurate estimating equation when you include serum cystatin C either by itself or with creatinine. And this got the attention of even the NIH director, Dr. Francis Collins, called for widespread use of serum cystatin C to try to help level the playing field so that everyone has access to kidney transplants and to prepare for dialysis in a timely way. All right, so this is just a summary slide. I'm not going to stay on it too long, but this is just for those who have a lot of interest in kidney disease. These are the estimates and measures that we have available to us. Each of them have their caveats and the issues that we just discussed over the last handful of slides. So one more thing, so when you're looking across men and women, I also just mentioned that there are differences in serum creatinine. So this is the serum creatinine distribution across GFR for men on the left-hand side and women on the right-hand side, stratified by race. And there are differences. These are statistically significant differences across race. And so by race and sex, we have to think about how creatinine levels might differ and account for that. And because serum creatinine has all of these issues, there are a lot of extra renal factors that are associated with it, including sex and race. That's why there is a shift toward a different marker that might perform better and provide more standardized measures and estimates of kidney function. This just shows you there's a lot of splay in what someone's GFR, their estimated GFR, is for a given measured GFR. So if you take a cross-section horizontally, you can see that someone who has the same measured GFR can have an estimated GFR from 30 all the way up to 60. That's a huge range on this scale. So we have a lot of issues when we're estimating kidney function. And this is something that we think about a lot. That's why I'm talking about it for so long today. It really is something that impacts patients' lives. It impacts our research, so we understand what's happening to these individuals and when do we consider something to be diseased or not diseased or progression of disease. These are really thorny issues. And so this is just some of the comparisons of the new equations, CKD-EPI. This is before we eliminated the race term, compared to the old standard, which had taken place in 1999 and been used for a decade or two before the CKD-EPI equations came out. Look at that splay and how different measured and estimated kidney function can be. So this just kind of shows that same picture from the prior slide. But as GFR gets higher, estimated GFR is higher, your actual GFR could be more or less than that estimate. So by quite a bit, plus or minus 30 units if you're out here with an estimated GFR in the normal range. So just keep that in mind. This is just another comparison of how well the CKD-EPI newer equations did to the older equations. And you can see if anything shows up on the right-hand side of these figures in these three panels, it favors the new equation. And you can see everything is on the right-hand side. The CKD-EPI equations did better than the old equation. And they also looked by different subgroups. And you can see here, both for men and women, these new set of equations performed better. So just to summarize this part of the talk about kidney function, and then we'll move on to talking about disease and risk factors. GFR is the most widely used index of kidney function. Measured GFR is imperfect. It's hard to perform, so we don't do it that much. And estimating equations are the feasible alternatives. This is what you get an estimate of when you go to see your doctor and you have blood drawn, and they give you an estimate of kidney function. Which equation is really up to investigators and hospital systems. And now we even have new equations that have just come out. New decisions are going to need to be made about how clinical care is going to be handled in light of the more recent publications that highlight STAT-C as a good marker. So how do we define abnormal kidney function and why do we want to? Clearly, if someone has lost a lot of their kidney function, they have abnormal or a disease state. But where do we use the cutoffs? So where do we find those cutoffs to define when does someone have a mild reduction or a moderate reduction in their kidney function? And why is it important? A lot of the work that has gone into defining these cut points has been based on a few things. So hemodynamic changes, also other adverse clinical consequences. So when do we see an uptick in hospitalizations or cardiovascular disease events, or increased risk of death? And all of those things happen as you move along the scale of GFR, and you see even mild reductions in kidney function can really increase your risk for bad things, for hospitalizations, for cardiovascular events, and other risk factors that go along with that. So there were a lot of definitions put out for chronic kidney disease. It really requires that you have a sustained level of a decline in kidney function. So we look for declines that sustain for at least 3 months. Structural abnormalities of the kidney without decreased GFR, and that can be manifest either in pathological abnormalities or markers of kidney damage. So if you have something going on with your tubules, you will have some things show up in your urine like protein and albumin, and that's also a marker in and of itself that can define you as having kidney disease. For the most part, though, we use a GFR less than 60 for 3 or more months, with or without kidney damage to define CKD. So going back to that slide I showed you about the differences of GFR, metric GFR, across the age span for men and women, you'll notice that using this cutoff of 60 is a decline of about 57% in young adulthood for men, only about a 50% decline in normal kidney function for young adults for women. So therein lies one issue. Quickly, that becomes more and more similar as you get to middle age. It's about a similar reduction, but it's something to think about as you do research across the lifespan to understand why you might detect more women versus men as having kidney disease, especially in younger life. And this is the cutoffs for GFR that are typically used, and this early stage requires that you also have some marker of kidney damage, so that urine protein or urine albumin. But 60 is a cutoff that we use quite a bit, and then again another 30 unit decline down to about 30. That's really advanced disease, and then when you're down in the teens and the 20s, that's when you have stage 4 kidney disease, and then as you get to a GFR less than 15, 10, that's when you're really talking about requiring dialysis, but you can also get kidney transplants in this next to last range. And something that has come into the forefront in recent years has been the importance of not only just GFR. Really, we use GFR almost solely to define kidney disease up until about 10 years ago. But this just shows the importance of increased levels of proteinuria and how they relate to bad outcomes, regardless of what your GFR level is. So on the x-axis is GFR in all of these panels, but across the different colors, these different lines depict different levels of kidney damage or those urine protein or albumin markers in your urine. And even at a given GFR that's sort of in the healthy range here, if you have urine protein or albumin, you're already at an increased risk for bad outcomes. This is cardiovascular mortality, all-cause mortality, using different measures of urine protein. So finally, this is the accepted kind of matrix that we now think about when we think about defining kidney disease. We look at two axes. We look at GFR, so that's what's happening at that glomerulus. And we also look at if there's any kidney damage to the tubule, we look at albuminuria, so albumin in your urine. As you get lower levels of kidney function and or higher levels of albumin in your urine, this heat map just shows the increased risk for reaching end-stage kidney disease. And it also, you could say, it also includes an increased risk for cardiovascular disease or death. Both markers are related significantly to those outcomes as well. So we updated these definitions. I'm going to skip over this. I just want to highlight, we now understand that albumin or protein in your urine is really a significant marker. You should not ignore that. So that's now part of the definition of kidney disease, in much more of a way than it used to be. And I have a couple of estimates from Catherine about 2010 estimates of the global burden of chronic kidney disease. We see age standardized on the left-hand side and the absolute burden in millions. So this is really a significant issue worldwide. Stages 1 through 5, that's anyone with any form of kidney disease, including just kidney damage without a decline in their GFR, or stages 3 to 5, which means that you really do have a decline in your kidney function. You have an issue in your glomerulus that's causing less filtration to happen in your body. So globally, this is stratified by men and women. We see in millions, in stages 1 through 5, there's more women globally that are defined as having any stage of chronic kidney disease or the more advanced stages of kidney disease. If you look at the age standardized prevalence, the same picture comes out. Prevalence of chronic kidney disease is higher globally in women compared to men. And that's somewhat related to what I showed you on that slide, where it takes less of a decline in your kidney function to be defined as having disease for women, because our GFRs start at different points. But there are differences also across whether you're in a high-income country or a low and middle-income country, whether or not that sex difference persists or is the same magnitude. And so there's a little bit of a difference here, but it's depicted really well on a couple of these figures that I'll show you. So this is the prevalence and burden of CKD, stages 1 through 5. So all stages in 2010 across the age span. And we see that women are in the kind of pinkish color, men in blue. At younger ages, there's less of a difference. And then as the age increases, women have a higher prevalence, age standardized prevalence of chronic kidney disease. And that's true for the prevalence and also absolute number in millions. So there's a difference in the prevalence. And this is across different regions now. Instead of the age span, now our x-axis is looking across different areas of the world. So globally, this is everyone in the first two pair of bars. Women have a higher prevalence. We saw that on that table. But we also see some differences here where there is not a sex difference identified in Latin America and the Caribbean. That sex difference that we note in other places reverses a little bit, maybe in the Middle East and North Africa. It's there again in South Asia, and then again, not as distinguishable in Sub-Saharan Africa. So it depends where you are in the world, but for the most part, those sex differences in the burden of chronic kidney disease persist. End-stage kidney disease is chronic kidney disease that results in either death, need for a dialysis, or need for a kidney transplant. So this is a really what we call a hard clinical endpoint, hard clinical outcome. There are a lot of consequences for it, and then of course it increases your risk for death. And if it is end-stage disease, you will die if you don't go on some form of dialysis or get a kidney transplant. Over the years, this is the adjusted incidence of end-stage renal disease or end-stage kidney disease. And over time, it increased until about the year 2000 when it started to plateau. It's gone down maybe a little bit, but we still see quite a bit of a plateau here in the 2010s. So the incidence of ESRD, although it was increasing in the 80s and 90s, now it's sort of leveled off from 2001. And now we're looking at it by gender, by sex. So in red are males. So this might be unexpected based on everything that I just showed you about chronic kidney disease. When you talk about end-stage disease, that really bad final endpoint, for people with kidney disease, more men reach this endpoint than women. Okay? So quite a significant increase. And this kind of persists throughout the years. If anything, may have diverged a little bit more to become more of a disparity across the sexes in the 2000s and 2010s. So very prevalent. The incidence is very high in men compared to women, something to keep in mind. So that does suggest some biological difference in men and women. We also have the adjusted prevalence of end-stage renal disease. It just goes up and up and up. People are living longer on dialysis and getting more transplants. That's one of the reasons why this continues to increase. And then this is just different ways that people are treated with end-stage kidney disease. Most of them are in this bluish, maybe bluish, blackish part of the figure. They go to a center and have in-center hemodialysis. Fewer people are agreeing with transplants. We're hoping to increase those numbers and those proportions. And this just shows across sex. Of course, the prevalence is higher in men, but proportionally, it's pretty similar. All right, and then I'm going to wrap up with just a couple of consequences slides. So when you have normal kidney function, you don't have all of these other risk factors that tend to cluster with chronic kidney disease. But as you have slight reduction in GFR, you might see some damage in the kidney, you might see some protein coming out in the urine. You have more of these comorbid conditions that show up. They tend to cluster together. The biggest risk factors are hypertension and diabetes. And when you start having those things, so your blood pressure elevates, you have higher glucose, you tend to have other issues show up as well. When we're able to detect either kidney damage or reduction in your GFR, there really are often other complications and other risk factors that are already present. And therefore, at those early stages, you can have a lot of complications. But then if you still progress to lose more and more of your kidney function, you're going to reach that end-stage disease or kidney failure, need dialysis or transplantation, and then often there's premature death that's associated with this continuum of kidney disease, unfortunately. So what are the main risk factors? I just mentioned a couple. There are some susceptibility factors that have been identified, but not that many. This list is shorter compared to others that I'm going to show you. There are some genetic and epigenetic variants that have been identified. Low birth weight and infant malnutrition is also associated with a susceptibility for CKD, but sex is also as well. And I showed you that in a lot of the data. So we saw that the prevalence is higher for CKD in women, but it's reversed. And I'll show that on the next slide. But with older age, you're also more susceptible to CKD. Risk factors for initiation of CKD, you could have a nephrotoxic agent that kicks you over into a disease state. You can have an infection. Hypertension is one of the leading causes, as is diabetes, obesity and metabolic syndrome, hyperlipidemia, cigarette smoking to a less degree, drug use, and when you have albuminuria, you're more likely to have reductions in GFR as well. And finally, once you already have CKD, these are the risk factors that are associated with further progression of that decline in your kidney function. Some things that are non-modifiable, like genetics, race, age, and sex. This is where we saw men had a higher incidence of end-stage disease, even though women have higher prevalence of chronic kidney disease. And a lot of the same factors that I just mentioned are associated both with initiation and progression. And then finally, there's some more novel risk factors that have been identified, but I won't focus in on those today. So just to bring it back to the sex differences perspective, so one of the more recent papers out of our study was in the Journal of the American Society of Nephrology and looked at sex-related disparities in CKD progression and death, and found when you compare women versus men, and this bears out what I just told you, women were less likely to reach end-stage disease or have a halving of their GFR, so losing half of their kidney function, or reaching that final stage of kidney disease, stage 5, compared to men. But women were also less likely to die. If they already have CKD, they're less likely to die with CKD, with or without censoring or end-stage kidney disease. So women had a lower risk of poor outcomes compared to men with chronic kidney disease at the same stage, and adjusting for a whole host of other factors. And then one paper that we published recently that I led also looked at a whole host of what we call kind of more novel risk factors. And this heat map just shows some hits that we got, things that are associated with progression of kidney disease. But really what's important for most people is these tried and true traditional risk factors that we always think about with kidney disease. They were very persistent even after we accounted for things that we thought were really important mechanistic pathways. These things like gender, sex, race, GFR at your starting point and your albuminuria and your blood pressure were some of the most important risk factors, even if we looked and accounted for all these other things. So finally, there are differences in all-cause mortality if you already had end-stage renal disease across the lifespan, and it differs by sex. So if you're a younger person with end-stage renal disease and you're female, you have a higher likelihood of all-cause death. And then this is the unadjusted prevalence of common cardiovascular endpoints. Across, this is the different modalities of treatment. This is only among men. So if you look at the pattern here, you see a pattern where NACVD is pretty prevalent. Unfortunately, if you have end-stage renal disease, heart failure is very common, as is coronary artery disease and peripheral arterial disease. And if you just keep this picture in mind, we're going from looking at what this picture looks like in men to what this looks like in women. And here we see similar patterns in NACVD and some of those other really prevalent cardiovascular endpoints. Excuse me. Finally, PAD is peripheral arterial disease, something we see often in chronic kidney disease. We also showed in another publication that it does differ by sex, and here we see it's more prevalent among women. And then finally, a paper that I led with a mentee at Penn showed different patient characteristics associated with different types of hospitalizations. Hospitalizations, unfortunately, occur very frequently in this population. And we look at all-cause mortality in the first panel, all-cause hospitalization, cardiovascular hospitalizations, and non-cardiovascular hospitalizations. And we see that when we look across sex, there are differences. And so women were more likely to have a hospitalization than men, but they were less likely to have a cardiovascular hospitalization. And finally, something we look at when we look at sex differences work, although with caveats, we need to make sure that we are powered to look at these differences. This is just a look at opioid use and kidney outcomes. And a whole host of different outcomes we're looking at here. Basically, progression of kidney disease are the top two panels, end-stage disease are the middle two, and death is at the bottom. And I'll just highlight here that when we're looking at end-stage disease, there is a difference across sexes in end-stage kidney disease for those who use opioids and those who don't. So just to summarize, relative kidney weight and length and nephron number differs by sex. So there are some anatomical differences. Age standardized prevalence across the world in CKD is different. We see that prevalence of CKD is higher in women, and the millions of people that have kidney disease really compels us to do a good job at estimating kidney function and also understand the risk factors and the sequelae. CKD progresses faster, and end-stage disease happens more frequently in men compared to women. And sex remains an important factor in the development and progression of CKD, even after we account for a whole bunch of other novel factors, so it's important. And sex modifies the effect of a lot of associations, so it's important if you're doing looks at risk factors and outcomes, if you think you're powered or if you think it's something that you can include to look at sex interactions. So thanks so much for your attention. I'm sorry to keep you guys a little late, but thank you so much. Let's see if we have Oh, so you want to get in here? Okay. If you have any questions, feel free. Email me, come by my office. I'm in 2018. Thanks so much for your attention.